Hi everyone, and welcome to ABCs of Anaesthesia. My name is Lahiri. I'm an anaesthetist from Melbourne in Australia. And today we have a special segment about ophthalmic anesthesia with Dr. Rahul Chakrabarti. Now, Rahul, he's an Australian subspecialty trained comprehensive ophthalmologist. He completed his ophthalmology training at the Royal Victorian Eye and Ear Hospital. He's a passion for surgical education and is currently the Director of Ophthalmology Training for the Royal Australian New Zealand College of Anaesthetists and Ophthalmologists, in Victoria, so that's RANSCO. Outside of medicine, Rahul is a father of three, plays acoustic blues guitar, enjoys tennis, table tennis, a lot of sports really, and also trekked to Mount Everest Base Camp. Sounds like Rahul, sounds like you're a typical overachiever. So, why?
Firstly, it's a very kind introduction. Thanks, Lahiri, for inviting me, and I'm really excited to talk about this topic. I try to squeeze in, much like you, as much as I can. And I guess over the last probably 5 or 6 years since finishing my surgical training, having experienced some hurdles in my last stages of my ophthalmology training, sort of inspired me to pursue a little career in pedagogy. And I've since completed a master's of surgical education, and I've taken over this role as director of ophthalmology training. So education really inspires me, and your channel and your work is really incredible. So I'm really privileged to be here.
Thanks, Ron. I mean, just to get it off the bat, I know that you've recently probably been arbitrating the RANSCO exams, the final exam. And, I know lots of people who haven't passed that first time. And, it is a difficult exam. There's not everything that you get told by your bosses is what's relevant for the exam itself. And, it's this real difficulty in having to learn so much information. It's very similar to the anesthetic exam as well. Is that why you got into it? Like to kind of try to make it as real or fair as possible?
Yeah, I think so. And also that, as you will know, that it's not textbook, the cases and the way that you need to actually prepare for the fellowship exam. So the first part generally, yes, can be quite didactic and fairly sort of textbook knowledge. But then the application of that is what's interrogated in the fellowship exam. So I'd encourage your trainees, as well as anybody else listening, to really immerse themselves in the clinical exposure and study smart. So you don't necessarily have to study hard, but you have to study smart. And that's the way to do that is obviously being in the clinical sphere and just discussing everyday cases and discuss it with your seniors, discuss it with your peers. Hey, how would you manage this? Get a spectrum of how a particular patient is managed in the real world. And the more you discuss that, the better you'll be prepared for the fellowship exams.
That's great advice. Like literally, I will provide opinions about certain scenarios, but I say, look, this is just one person's opinion and what I've seen my colleagues do, but that's your job, especially if you're not from Australia. You have to figure out what all your bosses are doing and find somewhere the average, what you do and what's reasonable. So no, that's great advice. Let's get cracking into, so, the aim of this is ophthalmic anesthesia isn't something that a lot of trainees have a lot of exposure to. I was lucky. I had some rotations where I did so much eye anesthesia that by the time I got into my advanced trainee years, everything was doable. But unfortunately, some anesthetists don't have that training. So by the time they become a consultant, they've barely done any anesthetics for eyes. And it's obviously a really popular thing to be a part of and very useful. So maybe the first thing to ask you is there anything particular that you wish your private anaesthetist maybe would know, or even public anaesthetists? I'll open that up to you.
Look, as you said, exposure to ophthalmology can be quite variable, and that goes back to all the way to medical school, really, and let alone being a junior doctor, depending on your exposures through training. I think I've been quite blessed in my private practice and also in public roles to have anaesthetists who have quite extensive experience in ophthalmology, both pediatric and adult. So I think a few key points. We can break it down into sort of preoperative, intraoperative, and postoperative points. So most eye surgery around the world, the most common procedure is cataract surgery. So we're going to touch a little bit on that, but there's a whole breadth of ophthalmic surgery. Okay, so I think just having an understanding of the nature of the procedure that you're going to be involved with from an anaesthetist perspective. And if you're not familiar with that, probably discussing with the ophthalmologist in terms of what their expectations are, what is this case that they're talking about, or what device that they're going to put in. I think that's the first point of call. So let's break it down and say preoperative. I think it's very important communication and terminology with the patient on the day of surgery, because for many patients, they're elderly and they may also be non-English speaking background or limited health literacy, and they can be petrified, even though it's a routine surgery for us, say, for example, cataract surgery, and it may be very standard case. The patient may be absolutely have no idea and really anxious. That can exacerbate their white coat hypertension. So from an anaesthetist perspective, to have to allay their concerns, be really calm on the day of surgery. Often the anaesthetist is actually the first member of the team who's interacting with the patient. So they're being brought in on the trolley into the perioperative bay. The patient's there, maybe with a family member. And that first interaction is really setting the scene for entire procedure that's going to happen. So that's one of the key points. Secondly, let's go into a bit more about cataract surgery.
And that really is, we know it's safe. We know this is a very safe surgery, but it is daunting because it's your eye. That's like one of the most tender parts of your body, really. So, you just really want your anaesthetist not to be trying to upregulate the sympathetic nervous system on these poor patients, just to be calm, be chilled, and go, yeah, you'll be fine. We'll take care of you. It's all going to be fine. Like, that's kind of the mode that we should be in.
And that's the reaction that I get from a lot of patients who have their first cataract operated, and then they come, the next day to see me in the rooms, and they'll say, wow, well, that was a fantastic experience. I don't have any pain. I don't know why I was concerned. And when can we book in the second eye?
Yep.
So, and that's an experience as a whole for the patient, starting from the anaesthetist to the surgeon to the post-operative nurses, etc. So, very, very important point.
Yeah, good.
Now, I mentioned that cataract surgery is the most common surgery that is performed by most ophthalmologists and probably around the world. One of the things that we do as eye surgeons is correct for astigmatism. So astigmatism is an irregular shape of the cornea. Everybody has a certain amount of astigmatism, but where it becomes a bit more of a large size, what we call more than one diopter or so, then we can, as eye surgeons, I can correct that with a particular type of lens that we place in the eye, an intraocular lens, which is called a toric lens. So as an anaesthetist, often the surgeon, the ophthalmologist will say, can you please mark the axis for the toric lens? And what they mean by that is marking the sort of reference axis, 0, 180, and sometimes even the inferior sort of 270 degree mark. And the key thing about that is that's happening before the eye is blocked or before the patient's sedated. So they're typically in the preoperative anesthetic bay, sitting up, upright and looking at a distance target. What you want to do is minimize the rotational effect of the eye if the patient's lying down. Because this lens, once the patient's brought into theatre, will get put in at a particular axis. And there are various methods by which we do that as eye surgeons. There are now softwares that are integrated through the operating microscope. But if the reference axes are not marked preoperatively and not marked accurately, that can obviously influence the accuracy of the lens position and therefore the refractive outcome ultimately for the patient. We're trying to minimize their dependence on glasses as much as possible.
And this is one of those interesting things, right? Because in public, they don't get covered for having toric lenses. So there's almost exclusively in private. I never even heard of toric marking until the first day. They're like, hey, can you mark eyes? I'm like, what do you mean? I can put a texter mark there. But yeah, toric marking. And so I will refer on the YouTube channel. I've got an ophthalmic anesthesia playlist. And I've got a way of how you toric mark with a robo marker as well as just with a texter, and everything you said. There's not something anaesthetists learn. I would implore everyone who's going through anesthetic training to find out from your surgeon in public when you're training, how do I do a toric marking? Because it's actually, no kidding, the hardest part of my job, because it is hard to keep an eye open on someone who's squinting or a 90-degree axis with someone with very small eyes. You have to get, worst case, you have to get like a speculum in there pre-lying the patient down and mark it properly. And then they blink and it smudges everything. It's actually more complicated than any other part of the anesthetic journey.
Yeah, I'm really glad that you have a section dedicated to that, and I'd encourage anybody listening to tune into that. There are different apps available too. There is an app called ToricCam, TORICAM, ToricCam. But basically, that's a camera embedded within a software in your smartphone, which uses the smartphone's inherent gyroscopic features. So if you don't have ToricCam app, you can still have a gyroscope app on your phone, and that can give you an approximate angle of rotation you, embedded into the on a patient
Rahul,
overlay of their eye.
what accuracy do you need? Because I know that most of my surgeons just need me to mark 0-180 as I see it, and that's going to be a couple of degrees out necessarily. Like how bad is the error margin on that you need?
Yeah, look, I think obviously minimal as possible, but practically, look, up to 2 millimeters is probably okay. The other thing I would add is in most private settings now, as ophthalmologists, we use overlay software that is actually integrated through the operating microscope. And so often most of my patients will have a photo of their eye taken pre-operatively when they come into my private practice. On the day of surgery, I'll bring a USB from my room, and that USB has taken a photo of their eye and looked at the conjunctival vessels. And the on the day of surgery, that preoperative photo is matched with the patient's eye on the table, and that automatically will mark or identify the axis that which the lens is placed. So most ophthalmologists in private practice, at least in Australia, and probably most of the developed countries, will have access to a toric alignment software.
So you're saying that lots of the times I won't even need to mark the eye?
Yeah, that's true. So it's worth asking your ophthalmologist, do you want me to mark the eye? Now, the reasons why somebody still may want you to mark the eye is A, because they might have not had their preoperative photo for whatever reason. B, one of the factors that can influence the reliability is if they've had a block and there's significant conjunctival chemosis, or suddenly your conjunctival photo looks very different from the preoperative photo. Okay, so it is always a good idea if you're placing a toric lens to still mark, or at least ask the ophthalmologist whether you'd like the eye axis to be marked, because we can still use that as a manual reference in theatre on the day.
Okay, good. Keep going. Yeah, this is great.
Yeah, so toric is a really important concept, because you'll find that definitely in private practice and also in public settings, albeit they have a higher threshold for when a toric lens is put in public. But there are more and more people using toric lenses in public hospitals. Another thing is suitability of posturing, supine. So obviously, most eye surgery, we would like our patients to be as flat as possible, at least the eye to be as flat as possible. And this is really important because it improves our surgical field of view, as well as the techniques and safety of eye surgery. But it's important to communicate if a patient is unable to lie supine, whether that's orthopedic issues, whether it's cardiogenic or genuine health issues, or it could be anxiety, claustrophobia, whatever it is. It's important to mention that to the ophthalmologist, and most of my anaesthetists do. It is not impossible to operate on a patient on a slight angle, but I think anything above 20, 30 degrees becomes technically challenging. And if you've got a patient that may require has a tricky operation planned ahead, and they can't posture correctly, that's going to make surgery a little bit more difficult. And ultimately, you want to do the safest and best operation you can. So then a discussion may need to be had in what else could we do? Could you increase the level of sedation? Perhaps some Trendelenburg posturing, whilst maintaining the eyes at a reasonably flat alignment relative to the head of the bed, and potentially the need for general anesthesia. Now, bear in mind a lot of our patients, cataract patients, are elderly. So they are typically will have multiple health comorbidities. They might not be able to lie flat. They might have rheumatoid arthritis in their neck, etc. So this is a really important conversation that needs to happen between the anaesthetist and the ophthalmologist to improve the safety.
Yeah, I've had so many of these incidents over the last few years, and it got to a point I was once working in a rural setting, and they cancelled a patient because the patient couldn't lie flat for whatever reason and panicked. And then when I saw the patient, it was sold as, oh, this patient will need a GA. And I just had a chat and said, oh, why can't you lie flat? He said his back aches a bit, and he could still lie 30 degrees. I just put him in a decent legs up Trendelenburg, so he was flat and his legs were up, so the angle of his body was fine. And he didn't need anything for that. He just needed topical and a tiny bit of sedation. And literally every single time I have this problem, we take it seriously, but most surgeons can deal with a little bit of a tilt, and you can almost always get your patient right. I've never had to give a GA for the purpose of this. Not saying it's not possible, but if you can do it without a general anesthetic in these pretty sick elderly patients, definitely worthwhile.
Absolutely. And the other common one is head tremor. So a patient might have just a benign essential tremor. They may have Parkinsonism. And most of the time, I've found having that conversation, just alerting the anaesthetist. And you'll find when the block is going in, just stabilizing the forehead, even with a gentle tape around the forehead to act mainly for proprioception for the patient, to remind them to stay still, just does the job. You might have a little bit more sedation than what you'd normally use. And very, very rarely would have to go to GA. So it's all about explaining that to the patient, getting their cooperation, and then working together as a team to provide the safest option, not necessarily the most extreme option. One other thing, prostatic issues causes a lot of problems for eye surgeons during cataract surgery. It induces something called intraoperative floppy iris syndrome, or IFIS. Now, IFIS is an idiosyncratic reaction for any male patient who has ever been on a medication for benign prostatic hypertrophy, so tamsulosin, Duodart, etc. And it's idiosyncratic, which means that the patient could have only had to taken it for a couple of days and then stopped. But it's done the job. Okay, it made the iris receptors and the iris sphincter very hypermobile, and it's lax. So it's just an issue for us as eye surgeons to be aware of, because then we can use techniques in surgery at the time of surgery to stabilize the iris so it's not coming out of the wounds, etc.
It's not just difficulty in dilating. This is also flopping. It's like two reasons really, but I assume that difficulty in dilation wears off after you stop using it, but this one's idiosyncratic. Exactly.
So the patient, if they're on the medication at the moment, preoperatively, there's no point stopping it because it's idiosyncratic. The receptors have already been triggered. So it's just something to be, communicated if it's not already noted by the ophthalmologist.
So if I see tamsulosin or Duodart, I'll say, oh, by the way, tamsulosin, middle Duodart, floppy iris, watch out. That would be something useful.
Yeah. And also preoperatively, you'll find in cataract surgery, the patients have on the day of surgery pupil dilating drops. Typically, these patients will have small, mid-dilated or poorly dilating pupils. So don't hit them hard with more and more topical drops. It's not going to do much. And in fact, once we start surgery and there's a lot of irrigation happening in the anterior chamber, those topical drops wash out very quickly. And typically you'll find that we have, as eye surgeons, we'll have to use other methods to dilate the pupil to allow optimal view of the lens.
Just on that point, like I've seen now more and more, so when I started, everyone just does the regimen of drops. And if it's not dilated, it's a bit of a problem. But nowadays I see even one surgeon doesn't do any drops and just does the intraoperative dilation. What do you think of that? Is that where it's going?
It's interesting. I think personally, I do like to have patients well dilated if possible with drops on the day of surgery. In terms of what regimen or concoction I use, most of my patients will have tropicamide, cyclopentolate, and phenylephrine, but phenylephrine at 2.5%. We've really gone away from 10% phenylephrine, which is still available in some pharmacies. We know that the higher concentration of phenylephrine can trigger not only cardiac arrhythmias, Takotsubo phenomenon, as well as spike their general blood pressure. So we tend to avoid 10%. And in certain patients, as we mentioned, patients on prostatic medications, there's another condition called PXF. The patient's pupil is not going to dilate very well. So in surgery, we will use a pupil expansion device, which you may have seen, and the variations of that. So I still feel that drops are important. It also allows a view of the lens when you start the case. So you might be able to assess whether there's anything different from what's being documented in the preoperative rooms, for example. And it doesn't really influence post-operative outcome.
Okay, that's good. Is it evidence-based that are there case reports of it causing, so phenylephrine 10% causing Takotsubo's? Or is that just a theoretical thing?
No, that's generally happened. There's, I think, been a couple of cases in Melbourne over the last decade. So I don't think anybody really, my colleagues, uses 10% anymore. 2.5% is quite safe. Okay. So what else do I wish my anaesthetist to know? So intraoperative, there's some advances in ophthalmic surgery that have popped up in the last few years, which we can talk about shortly. And then the other point I would like to just touch is postoperative. So just to, I guess, set the expectation to the patient on what to expect. So they might have some bruising and some redness around the eye, and just advising, setting the expectation for the patient. The one anaesthetist I work with actually calls the patients the following day just to check up on them. And I think that's an exceptional trait, but the patients really appreciate. Now, that might not be possible for many people from, working busy jobs. But I think having a method by which the patient could contact the anaesthetist if there are any issues or concern, that's also quite reasonable.
I find
because it's all a team effort. So.
Yeah, I definitely find often you get a patient who's worried about something, and it's often nothing that's too serious, like diabetic medications or whatever, or just even fasting status. And I just give them a call, and they're so happy to have received a call because it is quite unusual. And then all of their worry is just allayed in like a 2-second call, literally. I can see how that's an incredible value. Look, I might go straight on to these other questions about what's your opinion on subtenans versus retrobulba and peribulbar blocks? Do you have an opinion or strong opinion? Which one you prefer?
Okay, so let's maybe just before that, maybe for our audience who might be quite junior, some of whom have had a lot of experience in ophthalmology, I think broadly the techniques of anesthesia that we employ in ophthalmic surgery, so going from sort of extreme to another extreme, so topical anesthetic drop, maybe binoxonate, methocaine. The advantages, obviously, short acting. There's no akinesia, so the patient after surgery is seeing quite well, moving the eye normally. There's no double vision. It can always be augmented by the ophthalmologist on the table with intracameral lignocaine, usually 1% preservative-free. The downside of that is that really you're relying on patient compliance. So the patient to not be moving their eye, they understand, they have no hearing issues, so they're going to keep their eye still looking at the light. And depending on your level of experience, many people perform routine cataract surgery all the time under topical anesthesia. So then we're talking about anesthetic blocks at the next level. Retrobulba, most people, I would say, don't perform this anymore. There's a longer needle that goes into the retrobulbar space, as the name implies. And I think the reason it's gone out of vogue is the risk of complications. So the risk of bleeding, incarcerating a muscle, potentially damage to the globe itself because of the longer needle, potentially damaging the optic nerve. So a variation of retrobulbar is what we call peribulbar. So the needle is generally placed parallel to the orbital floor. I'm not going to go into techniques. I think that's covered elsewhere. But there's a shorter length needle, usually less than 31 millimeters. And the volume is between 5 to 8 mils of local anesthesia. There's variations of the technique, infratemporal or medial. They've got advantages and disadvantages for that. The risks of peribulbar is slightly more than subtenon, but less than retrobulbar. So there's still a risk of bleeding, a risk of hitting the globe, causing globe perforation, particularly with long and short axial length eyes. So when I mean long, generally more than 27 millimeters or longer, and short, really anything less than 22 should be flagged, but definitely less than 20 millimeters is a very small eye.
So, Rahul, I've always heard of globe rupture with a long eye due to staphyloma. I've never heard of globe rupture as a risk with a small eye. Why is that?
No. So the globe rupture, the small eyes cause other issues. So small eye, usually what we call nanophthalmos. So everything is a bit crowded. And when you do surgery, all the structures within the eye are really squashed together. So what you're trying to avoid is putting a lot of what we call posterior pressure, i.e. volume, behind the eye that's actually pushing the eye forward within the orbit. In the shorter axial length eyes, they present a lot of different challenges. And one of the things we might consider doing is giving pre-operative Diamox and even mannitol to sort of make the eye less firm, less tense. So the risk of doing peribulbar in these short cases from an anesthetic perspective is you could be damaging structures behind the globe rather than the globe itself, and then creating potential increased volume that's pushing the eye forward, what we call posterior pressure. Now, and the other main group of anesthesia is obviously subtenon. So the tenon's capsule, also known as the fascia bulbi. So it's underneath the conjunctiva, but it's above the sclera, and it also reflects around the extraocular muscles. This will give great anesthesia, blocking your conjunctiva, your extraocular muscles, not the optic nerve. And usually a smaller volume is required. Maybe 2 to 5 mils is sufficient. And the technique is usually inframedial quadrant, and a small incisions made in the conjunctiva, then blunt dissection down to underneath the tenon's capsule. And then you can use a blunt-tipped cannula or a subtenon cannula, which is blunt, to inject the volume of anesthesia. The downside of subtenon, sometimes, even if you in the subtenon space, you can get a bit of conjunctival chemosis. Okay, and so certain operations you really try to minimize that, particularly glaucoma surgery, as well as if you're doing a pterygium or any ocular surface, potential ocular surface cancers, because you really want to identify that area. You don't want everything to balloon up. But subtenon is by far a very, very safe option.
And just a quick question with the subtenons. And we always talk about the staphyloma globe rupture risk with retrobulbas and peribulbas, but if there is a staphyloma, particularly on the inframedial side that I'm inserting the cannula, do you have a concept of that risk of globe rupture?
Well, the cannula is typically blunt. So there's not going to be, and as long as you're visualizing your dissection plane when you're using your blunt tip curved scissors to actually access that plane, you should be safe, because you're really not passing those scissors too posterior. The only thing that's going posterior will be your blunt tip cannula. So that where the staphyloma is, whether it's equatorial, i.e. horizontal, or whether it's posterior staphyloma, so at the back of the eye, it doesn't really matter. Subtenons is very safe for staphylomas.
Yeah, good to know.
So in terms of your original question, what do I prefer? So that also goes back a little bit to the surgery that I'm doing, and the individual risk to the patient. So it depends on the individual case. And I would say with confidence, probably no one does retrobulba anesthesia anymore. So quick advantages, disadvantages again. Peribulba, personally, I prefer for most of my cataract surgeries peribulba. Why? Less conjunctival chemosis. And they're also better for pterygia because of the reasons there's less conjunctival chemosis. But again, we're trying to avoid it probably in patients on these novel anticoagulants, warfarin, long or short axial length patients, in which case you'd go to subtenons. Subtenons, the pro is it's easier for most ophthalmologists to do in theatre. So if the block is incomplete or it needs to be topped up, we can always top up subtenons under the microscope. Smaller volume for effect. So that's important, particularly in patients who are worried about eye pressure. So glaucoma patients, for example. And the downside is, though, slightly more conjunctival chemosis. In certain cases, you want to avoid that. And the level of akinesia is often not as good as peribulba. And this can be an issue for delicate vitreoretinal procedures, such as an epiretinal membrane peel. But that's probably fairly subjective. So most of the time, I do like peribulbas, having said all of this, for my cataract patients who I'm not doing under local anesthetic or topical.
Rahul, so you're a fast surgeon and you're going to have a quick list. So any surgeon who's quick, I always think if someone's saying they're doing a peribulba, they've got no proof of that. Because if their block is fast enough to be good enough for a quick list, then it's actually just called a peribulba, but really we're talking a retrobulba here just by another name. So I would always argue that there's obviously a bit of a controversial opinion. Lots of my mates do peribulba blocks, and if they're doing it with a fast surgeon, I'm just saying, look, who are you kidding? You're kidding yourself. You're doing a retrobulba. You've got low volumes. They're absolutely akinetic, and that wouldn't be possible in the time frame. Like back in the day, we'd use 7 mils, maybe top up with 3 mils. Would take time for the peribulba to work because our training surgeon is slow enough. And then I realized as I'm with these fast surgeons, I'm either doing retrobulba, which are kind of out of favor for the risks, and why not just do subtenons? And for me, my subtenons are pretty much akinetic. Not that with experience, you don't get too much swelling at all. And it definitely facilitates a fast list in what I would say is the safest way. What do you think about that statement of, I think my anaesthetists are fooling themselves by saying peribulba when it's actually the retrobulba?
Yeah, I think it's probably a bit of more of nomenclature, and perhaps the technique and the needle length is what we're sort of referring to distinguish those two. I think in terms of a fast list, that goes down to a few factors. So yes, anesthesia is one, surgeon is one, but also the operating theatre staff. So one of the centres that both you and I work at, they'll have a sterile room with the next tray or surgical instruments already set up. So once I finish my case, literally the patient is in the discharge to the post-operative recovery area. A new patient is already blocked, comes in, the equipment's already ready. So the turnover between the cases is less than a couple of minutes. And that flow is also highly important. And I'm not feeling as a surgeon that I'm rushing my cases. In fact, my operating is generally between 10 to 15 minutes per case, typically, and the turnover is a couple of minutes. So, I think in terms of the block itself, yes, probably your subtenon will take a little bit longer as a procedure, perhaps, to do. But overall, ultimately, it's whatever the anaesthetist is comfortable with. And I don't think it actually makes a huge difference to theatre flow if you've got all these other aspects of your operating environment optimized.
Yeah, no, that makes a lot of sense. Do you think as a principle, I know one of my surgeons, he had some really rare adverse events, really critical adverse events that happened because of a retrobulbar hemorrhage, which actually resulted in some really bad outcomes. So he's definitely gone the way of topical as the preferred choice because of these really rare events. What's your feeling? Is topical, generally speaking, the best way to go forward?
So, again, I think it depends on the patient and the severity of their condition. So, where I operate, both in the city and in a regional centre, the patients often have very advanced cataracts. They may be quite elderly, of non-English speaking background. So topical does require a level of patient cooperation and attention. So they really can't have any sedation. We're speaking mainly here for the audience about cataract surgery. So the patient is on the table. There's a light above them from the microscope. You're asking them to really focus on the light. and all the anesthesia that's been given is topical anesthetic. In a well cooperative patient with very minimal complications, anticipated complications, and no other ophthalmic issues, certainly topical, if you can do it, is excellent. So topical anesthesia with topical drops, and most of us will put a small amount, 0.1 mils of preservative-free lignocaine 1% intracameral, so within the eye at the start of the case. And that's important because as soon as you enter the eye as a surgeon, it can create some irritation to the iris muscle, and the iris muscle will quiver, and that can stimulate some pain for the patient. So remember, where the sources of pain are is basically the cornea, the conjunctiva, the extraocular muscles, and then the iris. So that's why we'll top up with intracameral anesthetic. So if all those factors are okay, then certainly go ahead and do topical. I guess it depends on if the patient has a really dense cataract. You may be worried about their pupil posturing, their ability to comply and listen in surgery. Then do the safest thing and block the eye.
Yeah, absolutely. I think I completely agree with that. That's what I see happening commonly, where you just really need cooperation. If you don't have that, it can be much worse for the patient rather than better, because the risk of a block is incredibly small, and the risk of someone suddenly moving during the operation is far worse, I imagine.
I would also just add that, touch wood, in my experience so far, I've only experienced one case of a patient having a retrobulbar hemorrhage from a peribulbar block. This is from being a registrar days to now consultanthood. So I would say generally, and this is working in very high volume ophthalmic centers. So I think, yes, I can understand the example that you mentioned with a consultant you've worked at, and it can be a very traumatic experience, both for the patient, of course, but also the ophthalmologist, because a retrobulbar hemorrhage is a time critical event, and can be potentially blinding. But most cases, I think a peribulbar or subtenal block is safe. One thing that has gone out of vogue is the Honan balloon.
Yes.
So typically, after the anesthesia, say a block would go in the past, people would apply pressure to the globe to sort of diffuse and get the anesthesia sort of working, dispersing itself through the orbit quicker. There have been multiple case reports, and not an insignificant amount, of ischemic optic neuropathy, because you're actually creating effectively an orbital compartment syndrome and you don't know it. So the patient has beautiful surgery, wakes up blind. Okay, so I think most of us have gone away from using Honan balloon or applying a pressure device over the globe after the block has gone in. And I think that's a safe approach.
Yeah, I now never use it, and an akinetic eye is just minutes away anyway. I see no point of this whole contraption. You got to sterilize, you got to clean it as well. It's just makes no sense for me. One of the common things that happens with patients that come in is they're all elderly with hypertension, and now you've got white coat hypertension, anxiety on top of that. I know one of my surgeons never wants the blood pressure greater than 160 for some complication reason. Do you have any preferences or hard no's for blood pressure? And it's probably more of an anesthetic question, but I might put it to you first.
So I would say, as an ophthalmologist, anything above 180 is systolic. Is probably I would avoid operating at that moment. And generally, the anesthetic team flags patients to me who have come in and their blood pressure is still up, and they have given them a small dose of something to attempt to bring down the blood pressure, and it's still elevated. And you just you have to err on the side of caution. The reason being, not only from a general health perspective, of course, your risk of strokes and so forth, which your audience is well knowledgeable on much more than me, but from an eye perspective, high blood pressure can increase the risk of something we call suprachoroidal hemorrhage. So a suprachoroidal hemorrhage is a rare but potentially vision-threatening pathology that manifests as a consequence of intraocular surgery, when blood from the ciliary arteries fills the space between the choroid and the sclera. And this is catastrophic for the eye if it happens in surgery. And so what this manifests as is the eye suddenly, you're doing surgery, goes firm, hard as a rock. And everything from the lens to the iris, it looks like everything wants to come out through your wounds.
Wow.
And one of the biggest risks, and the problem with this is even if you manage it to the best of your ability as an eye surgeon, the visual prognosis is really poor because there's extensive bleeding and high pressures. And one of the risk factors systemically for suprachoroidal hemorrhage is uncontrolled hypertension. So that's one of the main ophthalmic reasons why we would try and avoid operating on somebody with uncontrollable blood pressure on the day of surgery.
Interesting. And at that point, let's say the blood pressure was high, but less than 180, and this very rare event happened. At that point, is there something you need the anaesthetist to do? Like, do I need to get in there and absolutely control the blood pressure, get it down less than 160 or something like that? Or
look, intraoperatively, you certainly want the anaesthetist in the room. We will try to control the blood pressure, but systemically, some patients will need Diamox, systemically given IV. They may also need various ophthalmic surgical procedures to manage that as well. So yes, I mean, if that happens, it's catastrophic, very rare, again, as I mentioned, but yeah, you certainly would want the anaesthetist around to sort of help from a systemic management perspective.
I've got some reassuring advice. I guess I've been doing this for over 10 years now, and I've never had a patient, once I've given them some Fentanyl Midaz, even if they come with a blood pressure of 200, again, it's asymptomatic specifically. So if it's symptomatic, all bets are off. You need to get that sorted out. It's malignant. But if it's asymptomatic hypertension with a bit of Midaz and fentanyl, the blood pressure always goes down less than 160. And maybe once in 10 years, it hasn't. And you need the right drug that's short acting enough that or fast acting enough that its onset is for the period of the surgery, which is roughly 15 to 30 minutes of time. And then you really want it to wear off afterwards, so they're not suddenly hypotensive after the anxiety has released. So hydralazine is probably the best of that group, where you get 5 milligrams, top it with another 5 in 5 to 10 minutes, and that will last about the right amount of time. But yeah, thankfully with a bit of anxiolytic, this is very rarely a problem.
And look, the other, just in terms of post-operatively, we may prescribe a carbonic anhydrase inhibitor, such as acetazolamide. So probably the conversation between the ophthalmologist and anaesthetist about the safety of that. And the other point is aspirin and nonsteroidals really would like to stop or contraindicated because their antiplatelet function may promote continued hemorrhage within the eye. So if they're on something, that's another issue. Again, we're talking about a very rare condition, but that's the thing that ophthalmologists are largely worried about with very high systemic blood pressure on the day of surgery.
Yeah, okay. No, it's good to know. Next question is, I know the UK and even my hospital appointment in public has gone in the way of not fasting patients. And, if you look at massive numbers of patients, it's invariably very safe. Often these patients are getting no sedation, topical or a block. What are your feelings on fasting and, in different centers? Do you have any hard or fast rules for that?
Again, it's individual case, dependent. I certainly think that even if you put a block in the eye, you could probably in most cases perform cataract surgery without sedation, to be honest. In fact, I did a list yesterday exactly like that. So difficult cataracts, the patients had sedation, but the patients had Peribald or Subtenans block, but no sedation, and it went fine. The patients that you want maybe to consider sedation for, those who are perhaps you anticipate may move. So, they may have a medical reason for that. If we talked about tremor, Parkinson, they may be highly anxious. So I think there is a trend towards less sedation. But again, counseling the patient on the day of surgery and also prior to surgery that you won't feel any pain and you certainly won't be seeing instruments coming to your eye, but you'll be awake. You may hear voices. You may hear sounds of the machines that we use in cataract surgery. setting that expectation, because obviously patients are scared. They've probably been traumatized by going to the dentist and having other procedures performed. So they would like the idea of being, not aware of what's happening. But what they're actually scared of is pain. So once you allay that concern and the fact that they're not seeing instruments and other things coming to their eye, and most of the time the operation's finished and they said, "Oh, I haven't felt anything," that was okay. So I think there will be a trend of fewer sedation given.
And I mean, from the fasting point of view, I'm probably not one way or the other. I know that it is nice to have patients just not fasting, and they don't feel too bad when they've had a bit of a delay or the last on the list. But I think that there's enough, very rarely, maybe once every 5 years, someone might have a bit of a spell and become unconscious of a severe bradycardia or something like that. And I know when that happens, if they get unconscious, it is far safer that they're fasted. I think from my point of view, if they're having clear fluids, even clear fluids with something like a sugary drink or a black coffee or tea, I feel like that would be the middle line that I'd be pretty happy with for these patients, because essentially after 2 hours, having a fast for 2 hours with clear fluids is completely safe and a standard protocol. And I think it would mean patient comfort and just not being as stressed by this whole fasting experience as well.
Yeah, I agree with that. I mean, ultimately, we are performing eye surgery, and it is an operation. So I think very rarely we may need to convert, or something else goes wrong, and you really want to provide a safe environment for the patient at all times. So I don't think it's too onerous or a big impost for a patient to fast 4 hours before surgery. So.
Yeah, good. Hey, so one of the things I know in public it doesn't matter so much, but in private it's definitely a thing. And a lot of there's a wide audience for this podcast and YouTube, really, where some are starting out on their journey and some are finishing up in their journey. How important is a fast anaesthetist? I know that the practicalities of it is that you can have an extremely busy list. If someone's not efficient, that's essentially a bit of a deal breaker, I imagine. But you don't want someone who's too flippant and who's not thorough enough as well. How do you find that balance in your anaesthetist?
So again, I've been pretty blessed with having amazing anesthetists that I work with. And this question makes me think about two things. One, the anaesthetist and myself as a team, and working in the team. And I think that's the first and foremost. The other thing is experience. So experienced anesthetists tend to make things look efficient, but they're actually being very cautious and methodical and deliberate at every step, not taking shortcuts. What improves the efficiency of a list, I think, is understanding almost like an orchestra, understanding what's going to happen. So you get a pace feeling of how quick your surgeon is operating. The changeover, the interval between one case and the other, which is influenced by maybe the theatre nursing and the setup in the environment that you're working in. So understanding the mechanics of theatre flow is really important. And often when I start a list if it's a new anaesthetist or anaesthetist I've not worked with before, I might actually book fewer cases. I won't make it a heavy list. And I just get a feedback from the anaesthetist how that went. What do they think could we add more cases next time? Because there are many factors that influence efficiency. The first and foremost thing has to be patient safety. And you don't want to make anybody in the operating team uncomfortable or feel pressured. And I'll just go back to the point that most of our patients in ophthalmology, certainly in adult cataract surgery, are elderly patients. Okay, they may have multiple comorbidities. They may have limited English, limited healthcare literacy. So it's important not to overlook these things. So yes, having an anaesthetist who is efficient is obviously excellent. What I tend to find is, as I'm doing one operation, my anaesthetist, and I'm sort of finishing, my anaesthetist is blocking the next patient. But that rapport can take a list or two to get a feel for. You probably don't want to do that straight away in your first list with a new surgeon or a surgical team. And so after that, first few lists, then you can certainly say, how do you feel? And so you don't want to block too many patients ahead and have a slow surgeon. So it might take a list or so to get that that rhythm.
Yeah, that's actually really
But
helpful of you, Rahul, because I got to say, there's no ophthalmologist I've ever worked with that has decreased the numbers on the list for me. So I actually, that's really kind of you that you do that, because I think that's actually really great. Because you're right, it's many factors. If I get a new nurse who's never worked there, I have to be so extra careful because all the flow is just gone, and it's got to be patient. It's not, it's not their fault. They're not familiar. I might be a new hospital. I depend on the nurses to tell me how things go, and I leave it up to them essentially. If it's a new place, I go, what do we do now? I mean, okay, I'll block now. What do we do now? Okay, I'll put a drip in now. They'll show me what flow has worked, and I'll go with that. Just like a new nurse coming to me, I will show them the flow that has worked for us. But there is some things I remember thinking. Every time I do any procedure, I really go, what is the worst case scenario here, and how can I prevent those as a systematic thing? And I've just got a few things I might as well mention. For example, you're looking after up to 3 patients at once in some situations. Not all of them are sedated, but 2 might be lightly sedated. And anyway, so you've got a few patients that you're dealing with. I have this rule that every time I interact with the eye, I look at the consent before doing it. So if I'm dropping an eye, I say right eye, drop. Washing with betadine, right eye, betadine. Block, right eye. Every time the consent is on the chest, and I'm looking at that, never leaves the chest. If I've got medications, I put them in a sterile, aseptic container on the patient, so it never leaves that patient. Because if there's any kind of movement of that medication to another spot, someone might think, oh, that was for the last patient or the first patient, and they're not sure. So it never leaves that spot. And then the other thing is, I know ANSCA monitoring doesn't require ECG to be on, but it should be present. And I've just realized I've had enough pretty crazy bradycardias in 10 or so years of doing this that I'll just put ECGs on everyone, because sometimes the SATs doesn't work, and it's not because of a bradycardia. But I know that the ECG, if I see a heart block or a brady or something like that, this is definitely something I want to know straight away. And what is it? There's no problem putting a couple of dots on the chest. And I think the final thing, actually, just on a side note, is that I think most patients that come in, it's going to be fine, right? This is a very low risk operation in stable patients. But I think of it as an opportunity for a patient who's maybe not seen a specialist to have my eyes on them and your eyes on them. And we've diagnosed some crazy things in patients that they came for a cataract, and then they left with, we discovered renal failure or uncontrolled diabetes, or even potential cardiac compromise, or a severe valve lesion. And I think that's part of the game. Like, you have to be able to look into those things that might protect the patient in the next 5 years, even though you're just doing a cataract. And I think that's pretty cool that we get to do that.
I completely concur with you on that, and I think it's really amazing that you have these sort of checklists that you do, and having that routine. And so you having a structure and things that you do is really important, whatever procedure you're involved. And I totally agree with you. Also, what I'd like to add is that that moment that you have in the anesthetic bay before surgery, if you're identifying some issues, that's really important to then flag to the ophthalmologist. We don't want to have an issue in theater and you just started the cataract, and then now somebody's saying, actually, the patient's, I don't know, having some serious heart block issue that we might have detected, a few minutes ago before starting the operation. It's always better to communicate that if you can identify things early, and then we can say, actually, look, Mrs. Jones, I don't think you're sorry, but there are some issues that have been identified today. We might need to reschedule your surgery and get your general health sorted because of some critical issues that have been flagged. So you're absolutely right. It's an opportunity for us to work collaboratively to look after a patient, not only their eye.
Yeah, no, that's right. And it's an elective procedure. They can always come back for the eye. We can absolutely make this an opportunity for them to, improve their overall health. They don't need to come for surgery right away. So, yeah.
I think one thing that the pandemic has done is patients are quite comfortable in having their surgeries in some ways cancelled or rescheduled, because everybody's sort of aware of the reality. So it's not too big a surprise if something for a health reason pops up and we have to reschedule.
Yeah. Hey, Rahul, so we've probably gone for about an hour, which is about right. I think we covered an amazing amount of things. Is there anything else you want to kind of say in this sphere at all?
Look, I think I think we've covered a lot, and it's been great. I just wanted to emphasize that point about the anaesthetist and the ophthalmologist working as a team, and certainly all the centers that I work at, I have amazing anaesthetists, and I actually mentioned that in my preoperative consent. When I'm in the rooms, whether it's pediatric or adult, and I tell the patients, some of them want to know the anaesthetist's name, and I give them their name, and I say, look, I've worked with this colleague for almost a decade, both in public and private, and we work well as a team, and I trust them, and so that's a healthy relationship that you build with your surgeon and the surgeon with the anaesthetist. So I think having this podcast just reflects, that as well. And so I'm really appreciative of you inviting me.
No, thanks so much, Rahul. And I mean, just to recap, I think we went through so many things, what you wish your anaesthetist knew about you. I think you mentioned things that would really impress you about your anaesthetist and be kind of a decision point of, I like the way they work. We covered Subtenan, retro and Peribald, as well as topical. Talked about some contraindication, indications, pros and cons of that, some blood pressure aims, toric marking, how that's something you'd learn really as you graduate, but probably should learn about it even before. Talked about fasting, use and also uncontrolled hypertension and the potential for suprachoroidal hemorrhage. And finally, just the efficiencies of what we do. What does efficiency mean? And having a good team, having a really good collegiate environment, nurse, doctor, ophthalmologist, and anaesthetist. So thanks very much for being on the program. So we might end it there. Please reach out if anyone wants any more information. I'll put links for various things in the notes, and please share with anyone who might be interested. This will be out on YouTube as well as the podcast, obviously. So thanks very much, Rahul, and we'll see you all next time. Now, what's new with ABCs of Anaesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anaesthetic journey, from medical student to procedural skills, from foundations in anaesthesia, as well as really important exam lectures and clinical anaesthesia courses as well.